Hello class, so today we're going to discuss spinal cord injury and the physical therapy interventions. So the learning objectives of this study is for you to be able to differentiate between complete and incomplete spinal cord injuries. We'll use the Asia guidelines to classify people with spinal cord injury as A, B, C, D, E. Discuss the various levels of spinal cord injury. We'll be able to relate the neurologic level of spinal cord injury to the functional capabilities of the patient and teach rehabilitation strategies for people with various levels of spinal cord injury. And we'll discuss that further in our laboratory time. So let's discuss the major tract systems of the spinal cord. We have the corticospinal tract, the dorsal column medial lemniscus system, and the anterolateral system. So the spinal cord contains several major tract systems that serve as pathways for sensory and motor information between the brain and body. Here's a breakdown of the three primary tract systems. We have the corticospinal tract. So the function is this is a major motor pathway responsible for voluntary movement. It controls fine skilled movements, especially in the distal muscles of the limbs, like your hands and your fingers. So the pathway originates in the motor cortex of the brain, from the name corticospinal, and it travels down through the brainstem and spinal cord. In the lower medulla, most of the fibers decussate, meaning it crosses over to the opposite side, forming the lateral corticospinal tract. So this crossing allows each hemisphere to control movements on the opposite side of the body. A smaller portion remains uncrossed, and that's your anterior corticospinal tract. So when you hear about corticospinal tract, you have two portion, which is the lateral corticospinal tract, the bigger portion that crosses over, and the smaller portion that remains uncrossed. So that's your anterior corticospinal tract. So what's the clinical significance? If there's damage to the corticospinal tract, it can lead to upper motor neuron signs. And what are these signs? There's spasticity, weakness, and positive Babinski sign, where the big toe moves upward upon stimulation. So the second major tract system is your dorsal column medial lemniscal system. So the function of this system is primarily responsible for carrying sensory information related to your fine touch, vibration, proprioception, which is the awareness of body position and pressure. It plays a critical role in providing the brain with detailed sensory information. So, what's the other name for your dorsal column medial lemniscal system? This is your dorsal column. Okay, so what's the pathway for this one? So the sensory information from the periphery will enter the dorsal root ganglia, and it will ascend in the spinal cord through your dorsal column. So you'll see the fasciculus gracilis, which is responsible for your lower body, and your fasciculus cuneatus for the upper body. And then its synapses in the medulla. Okay, so here in the medulla, the information then crosses to the opposite side of the brainstem in the medial lemniscus pathway, and then it ascends to your thalamus, which is the relay station, right? Before it actually reaches the primary somatosensory cortex. Okay, so the damage to the dorsal column medial lemniscal system or pathway can result in loss of your proprioception and fine touch, leading to sensory ataxia, which is there's impaired coordination. Even though there's no weakness. So, impaired coordination without weakness, where patients have difficulty with precise movements, especially in the dark or when their vision is obstructed. We also have the anterolateral system. which is one of the ascending tract. This is also known as your spinothalamic tract, which is involved in also carrying sensory information, but the sensation is related to pain, temperature, and crude touch. This system allows the body to detect harmful stimuli and respond quickly. So just remember the differences of sensation that it is responsible for. So the pathway for this one, the sensory information related to pain and temperature will enter through the dorsal root ganglia again, and it will synapse in the dorsal horn of the spinal cord. Then the decussation or crossing over is within a few segments only and ascends on the opposite side in the anterior and lateral portion of the spinal cord, not into the medulla. Hence the name anterolateral, because it ascends and crosses over the opposite side in the anterior portion and lateral portion of the spinal cord. Okay, the pathway continues to the thalamus again and then to the somatosensory cortex. So again, the difference is where it actually crosses over. It crosses over one to two segments of the spinal cord. So lesion in this anterolateral system or spinothalamic tract can lead to deficits in pain and temperature, but remember, it's on the opposite side of the body that is relative to the lesion. So conditions like syringomyelia, which disrupts this pathway, can also cause cape-like loss of pain and temperature sensation over the shoulders and upper limbs. Okay. So what are the differences again for these three major tract systems? Corticospinal tract is for motor control. It crosses at the medulla and it's for fine motor movements. The dorsal column medial limniscal system is responsible for fine touch, proprioception, and vibration, and it crosses at the medulla. The anterolateral system is responsible for pain and temperature sensation, but it crosses at the level of entry in the spinal cord. Understanding this tract system is crucial in neurology and physical therapy for diagnosing and treating your spinal cord injuries and neurological dorsal roots, neurological disorders. So, next, we're going to discuss the spinal cord. So, let's talk about in here it shows segmental and vertebral levels, okay, and it's compared between the first cervical, first thoracic, first lumbar, and first sacral cord segments. So remember that the spinal nerves 1 to 7, which is cervical, emerge above the corresponding vertebrae, and then the remaining spinal nerves, starting from C8, emerge below the vertebrae. Okay, so that's one of the basic things you need to remember. So let's talk about the dorsal root and the spinal cord. Okay, so the dorsal roots of the spinal cord are essential components of the peripheral nervous system. Remember the word peripheral nervous system because it's already outside of your spinal cord, and it's primarily responsible for carrying sensory information, okay, from the body to the central nervous system. So when it's a dorsal root, it is actually for sensation or sensory. So let's talk about the structure and anatomy. How many spinal nerves pairs do we have? So we have 31 pairs of spinal nerves in the spinal cord, and each attached to the spinal cord by which one? By the posterior and the anterior roots. Okay, so the dorsal roots are the posterior segment of each spinal nerve, and it emerges from the dorsal backside of your spinal cord. So each dorsal root, remember, will contain your sensory nerve fibers. So it is also called your afferent fibers. Okay, so within the dorsal root is a dorsal root ganglion. Okay, so which houses the cell bodies. When you say ganglion, it is where all the cell bodies of the sensory neurons are. So these neurons are pseudo unipolar, meaning they have a single projection that splits into two branches. So one branch extends to the periphery, gathering the sensory information, okay, while the other projects centrally, going to the spinal cord. So what's the function of our dorsal roots? So the primary function of the dorsal root is to transmit sensory information from the body to the spinal cord and subsequently to the brain for processing. So they carry various types of sensory input, including the, your proprioception, awareness of body position and movement. It carries fine touch, detailed sensation of touch, carries vibration, detection of vibration stimuli, pain and temperature, carried by specific sensory receptors. So, after entering the spinal cord, sensory fibers then can synapse at different levels depending on the track that they follow. So, some fibers enter the dorsal column medial lemniscal pathway, which will relay fine touch, vibration, and proprioception. So the other kind of sensation will enter the anterolateral pathway to relay pain and temperature information. So it depends of what kind of stimuli they're going to carry. They will go to a different pathway. So the damage to the dorsal root can lead to sensory deficits. So this may result conditions like what we talk about paresthesia, which is an abnormal sensation such as your tingling and numbness or numbness. So anesthesia when there's loss of sensation in a particular area, when there's loss of proprioception, difficulty in maintaining the balance and coordinating movements, as body cannot accurately sense where its position. There could also be radiculopathy, so it's often caused by compression or injury to the nerve root, can lead to pain and sensory deficits in the areas supplied by the affected dorsal root. This is common in conditions like your herniated disc or spinal stenosis, where the root may be compressed and there will be radiculopathy. There's also what we call dorsal root ganglion pathology. So, infections like your shingles, herpes zoster, it can affect the dorsal root ganglion, leading to painful segmental skin eruptions along the affected dermatome. So, this is really a painful problem. So the dorsal roots of the spinal cord are essential for relaying sensory information to the brain. So they house sensory neuron cell bodies in the dorsal root ganglion, and they play a crucial role in our sense of touch, pain, temperature, and proprioception. The dysfunction in these roots can lead to various sensory impairments, making their integrity vital for proper neurological function. So, what does the posterior root or spinal nerve carry? Okay, looking at the dorsal root again. So the posterior root, also known as the dorsal root of the spinal nerve, it carries sensory or afferent information from the body going to the central nervous system. So specifically, it transmits sensory signals related to touch, proprioception, vibration, pain, and temperature. So the dorsal root contains sensory neurons whose cell bodies are residing in the dorsal root ganglion. So this ganglion is a swelling along the root. These sensory neurons are again pseudo unipolar, which with one branch extending again to the periphery to receive sensory input and the other branch entering the spinal cord to relay that information centrally, going to the spinal cord and then to the brain. So the posterior root exclusively carries sensory signals from the body to the spinal cord, providing essential information for sensation, balance, and the perception of potential dangers. How about our ventral roots? What does it carry? So, the ventral roots of the spinal cord carries motor or efferent information. Again, it's coming from the central nervous system, now going down to the body's muscles and glands. So let's look at an overview of the ventral root's role. So it provides motor signals, right? The ventral roots contain the axons of motor neurons whose cell bodies are located in the ventral anterior horn of the spinal cord. So these neurons send signals from the spinal cord going to the skeletal muscles, initiating and controlling what kind of movement? Voluntary movement. So let's talk about also autonomic signals. So regarding the anterior ventral roots. So in certain segments of the spinal cord, the ventral roots also carry autonomic or involuntary motor signals to smooth muscles, cardiac muscles, and glands. So for instance, in the thoracic and upper lumbar region, the ventral roots contain sympathetic fibers. Remember that thoracolumbar, in the ventral root, it contains sympathetic fibers, which are part of the fight or flight response. In the sacral region, the ventral roots carry the parasympathetic fibers, which are involved in rest and digest functions, and some are located in our brainstem. Okay. So in summary, the ventral roots carry motor or efferent fibers that control both voluntary skeletal muscle movements and involuntary autonomic functions, allowing the central nervous system to regulate the body actions and responses. You can also see here the cervical enlargement. So this is a region of the spinal cord that is expanded, okay, to accommodate the increased number of neurons needed to control the muscles of the upper limbs and to process sensory information from the arms and hands. So here are the main aspects of the cervical enlargement. The location is this is a cervical enlargement that is located in the cervical region of the spinal cord and specifically between C5 and T1. Its function, okay, is responsible for supplying nerve fibers to the brachial plexus, okay. It innervates the shoulders, the arms, and hands. So it also contains a higher concentration of motor neurons for fine control of the upper limbs and sensory neurons to handle complex sensory inputs from these areas, okay. So the cervical enlargement is thicker than other parts of the spinal cord due to the increase in gray matter, okay, particularly in the ventral horns for the brachial plexus, okay. It contains the cell bodies of motor neurons. So these neurons are necessary to handle the precise and complex movement of the upper extremities. So what's the clinical relevance for this cervical enlargement? So, a damage to the cervical enlargement, such as through spinal cord injury or trauma at this level, can result in significant loss of function, leading to weakness or paralysis in the arms and hands, as well as potential sensory deficits. So, conditions affecting this area are particularly impactful due to its role in upper limb movement and sensation. So the cervical enlargement is a widened area of the spinal cord, as you can see, okay, in the lower cervical region. So essential for upper limb motor control and sensory processing, making it vital for hand and arm function. How about the lumbar enlargement? So the lumbar enlargement is a widened area of the spinal cord in the lower back that serves to accommodate the increased number of neurons necessary for controlling the muscles of the lower limbs and processing sensory information from the legs. So to take a closer look again, it is located in the lumbar region of the spinal cord, typically between the T11 and L2 vertebrae. However, it is often referred to as the lumbar enlargement because it supplies nerves to the lumbar and sacral regions of the body. So this enlargement provides nerves to the lumbosacral plexus, which innervates the pelvis, legs, and feet. It contains a high concentration of motor neurons to control the muscles in the lower limbs and sensory neurons to handle input from the legs and feet. So, similar to the cervical enlargement, the lumbar enlargement is thicker due to an increase in gray matter, particularly again in the ventral horn. So, these ventral horns contain the cell bodies of motor neurons responsible for the intricate movements of the lower extremities. So, injury or disease affecting the lumbar enlargement can lead to weakness, paralysis, or sensory deficits in the lower limbs. So, conditions such as spinal cord trauma, tumors, or degenerative disease in this area can impair leg movement, reflexes, and sensation, significantly affecting mobility and quality of life. So the lumbar enlargement is a region of the spinal cord that serves as a hub for motor and sensory neurons dedicated to the lower limbs, making it crucial for leg function and sensation. You can also see your conus medullaris. This is the tapered cone-shaped end of the spinal cord, making the termination of the spinal cord proper. The conus medullaris is located around the L1, between L1 and L2 vertebral level in adults, and in children it's between L2 and L3. This is the point at which the solid spinal cord ends and it gives way to the cauda equina, which is a bundle of spinal nerves that continues downward. Okay. So the conus medullaris has a tapered structure transitioning from the full diameter of the spinal cord and then to a pointed end. It contains lower lumbar and sacral and coccygeal nerve roots which exit the spinal cord and descend as part of now the cauda equina. So the conus medullaris plays a critical role in containing nerve cell bodies and fibers that contribute to lower limb and pelvic organ functions. While the spinal cord itself ends at this level, the nerve roots that originate here continue within the spinal canal to exit at their respective vertebral levels lower down. So, an injury to the conus medullaris can cause the conus medullaris syndrome, which is a condition characterized by the lower limb weakness or paralysis. There's also loss of sensation in the legs, buttocks, or perineal area. It's often in a saddle distribution. There's also bowel and bladder dysfunction due to the involvement of the sacral nerves that is responsible for controlling these organs. There's also sexual dysfunction as these nerves are also affect the sexual function. So, a damage to this area can result from trauma, tumors, spinal stenosis, or infections, and its effects may overlap with those of cauda equina syndrome, although they involve different nerve roots and present with some distinct symptoms. So, in summary, the conus medullaris is the terminal portion of our spinal cord and it contains nerve roots that influence the lower limb and pelvic functions, which is essential for lower body sensory and motor control. And we have also the phylum terminale is a slender thread-like extension of connective tissue that extends from our conus medullaris anchoring the spinal cord to the coccyx. The phylum terminale starts at the conus medullaris at about the L1 L2 vertebral level and then it extends downward to attach to our coccyx. The phylum terminale is composed mainly of pia mater, okay, one of the three meningeal layers, okay. It surrounds and protects the spinal cord. So, again, the function of phylum terminal is to stabilize and anchor the spinal cord within the vertebral column and attaches to the coccyx, and it prevents excessive movement of the spinal cord within the spinal canal, and particularly during bodily movements like bending or twisting. So, in some conditions such as the third cord syndrome, the phylum terminale can become thickened or abnormally taut. It restricts the movement of the spinal cord. So this tension can lead to neurological symptoms including pain, weakness, and sensory changes in the lower limbs, as well as possible bowel and bladder dysfunction. It requires sometimes surgical procedures to release or untether the phylum terminal, and are sometimes performed to relieve symptoms and prevent further neurological impairment in such cases. Okay. Lastly, we have the coccygeal nerve. It is the most distal or lowest spinal nerve in the human body, and this is a single pair of spinal nerves, just one on each side. Okay. It emerges from the conus medullaris at the very end of the spinal cord, and it exits through the sacral hiatus, which is an opening at the lower end of the sacrum. Okay, so the function of this one is it provides sensory innervation to the skin in the coccygeal or tailbone area, especially around the anus area. It also contributes minor motor and sensory input in the region, aiding in the innervation of the skin and certain muscles that are around our coccyx. Okay. If we have damage or irritation to the coccygeal nerve, it can lead to coccydynia or tailbone pain, which can be caused by trauma or prolonged sitting or inflammation. So this is the final spinal nerve providing sensory input to the skin over the coccyx and limited motor function in the surrounding region. And its role is relatively minor compared to the other spinal nerves, but important for sensation and function in the lower spinal area. So in this picture, you will see the meninges of the spinal cord. We have the dura mater, arachnoid matter, and pia matter. So let's just discuss briefly on this one. The dura mater is the outermost and toughest layer of the meninges, and it is composed of dense fibrous tissue and forms a protective sheath around the spinal cord. And its function is it serves as the first line of defense against mechanical injury, and it also helps to contain cerebrospinal fluid within the subarachnoid space. So the space between the dura and the vertebrae is called the epidural space. It contains fat and blood vessels. So this space is where epidural anesthesia is administered, okay, in the epidural space, okay, during certain surgical procedures or childbirth to block pain in the lower body. So another meninges is the arachnoid. Okay, the arachnoid matter is a thin web-like membrane located just beneath the dura mater. It is named for its spider web-like appearance due to its delicate fibers. It is an additional protective barrier for the spinal cord. Between the arachnoid matter and the pia mater, we have the subarachnoid space, which is actually filled with the CSF. And this CSF cushions the spinal cord, provides nutrients, removes waste, and helps maintain a stable environment. So the subarachnoid space is accessed during procedures like the lumbar puncture or the spinal tap, to get a CSF sample for diagnostic purposes. So inflammation of the arachnoid matter, often from infection, is known as arachnoiditis, and it can cause pain, numbness, and neurological issues. So the last meninges is the pia mater, and it is the innermost delicate layer that adheres closely to the surface of the spinal cord and brain. It is highly vascularized, okay? It contains blood vessels that supply oxygen and nutrients to the spinal cord. And so the pia mater helps nourish the spinal cord and also contains the denticulate ligaments, okay, which anchor the spinal cord laterally or to the sides to the dura mater, and it provides stability within the spinal canal. So the pia mater extends down from the conus medullaris as the phylum terminale, and it anchors the spinal cord to the coccyx. So any damage or inflammation of the pia mater can disrupt the blood flow to the spinal cord, and then of course it will impair its function. Okay, so as a summary, the dura mater is a tough outermost layer that provides strong protection and forms the epidural space. The arachnoid mater is a middle web-like layer. It encloses the CSF-filled subarachnoid space, and the pia mater is a delicate vascular layer, closely adheres to the spinal cord and provides nourishment and stabilizes it with denticulate ligaments and phylum terminale. So you could also see in here the white ramus and the gray ramus. So um, just to tell you the differences, the white ramus contains myelinated, that's why it's white, okay, preganglionic fibers, and only found from T1 to L2. It carries signals from the spinal cord to the sympathetic ganglia. So the gray ramus contains unmyelinated, making it gray, postganglionic fibers and present at all spinal levels, and it carries signals from the sympathetic ganglia back to the spinal nerves for distribution to target organs. So we have the Asia, which is an international standards for neurological classification of spinal cord injury. So this is the American Spinal Injury Association, Asia. So the components of Asia classification, it has sensory examination. Okay, it assesses the sensory function across 28 key points on each side of the body. You can see motor on the left side, sensory on the right side. Okay, so the sensory examination, it assesses sensory function across 28 key points on each side of the body, corresponding to each dermatome from C2 to S4 to S5. There are two types of sensation that are evaluated. We're evaluating light touch, pinprick, by using sharp or dull discrimination. So each sensory point is graded on a scale of 0 to 2. Okay, 0 is absent, 1 is impaired or altered, 2 is normal. There is motor examination as well, and that's on the left side, which is the key muscles. Okay, it assesses motor function in key muscles associated with 10 paired myotomes. So it will use 5 in the upper limbs and 5 in the lower limbs on each side of the body. So each muscle group is graded on a 0 to 5 scale. So 0 for total paralysis, 1 for palpable or visible contraction, 2 for active movement with gravity eliminated, 3 for active movement against gravity, 4 for active movement against full resistance, against some resistance, and 5 active movement against full resistance or normal strength. So this is like doing your manual muscle testing. So the Asia impairment scale, okay, grades. We have the Asia scale classifies injuries from A to E based on motor and sensory function. So the Asia A, it is called complete. Okay, there's no sensory or motor function that is preserved in the sacral segments of S4 to S5, indicating a complete spinal cord injury. So the Asia B, it's sensory incomplete, meaning the sensory function, there is sensory function but not motor function. So sensory function is preserved below the neurological level of injury, including the sacral segments S4 and S5. So Asia C, it's motor incomplete. The motor function is preserved below the neurological level, and then more than half, Remember that more than half of the key muscles below the level of injury have a muscle grade of less than 3, but cannot move against gravity. Asia D, it's motor incomplete also, but motor function is preserved below the neurological level, and at least half of the key muscles below the injury level have now a muscle grade of 3 or more, which meant to say it can move against gravity. And then of course Asia E is normal motor and sensory function. So this grade is assigned if the individual had a prior SCI but has since regained full function. So the key concepts in Asia classification is the neurological level of injury, the lowest segment of the spinal cord with normal sensory and motor function on both sides of the body. Okay, so for zone of partial preservation, and this is for incomplete injury, some motor or sensory function may be preserved below the injury level, but it does not extend to S4, S5. Okay. So what is the clinical importance for this one? So the Asia classification provides a consistent method for assessing SCI severity and allows clinicians to communicate effectively regarding a patient's neurological status. So it aids in predicting recovery potential. So for example, incomplete injuries, Asia B, C, and D generally have a better prognosis for some degree of motor and sensory recovery compared of course to complete injuries Asia A, right? So for treatment planning, knowing the Asia grade helps guide rehabilitation and therapeutic interventions tailored to the level and severity of function loss. So, the Asia Standard Neurological Classification provides a detailed framework for assessing and grading spinal cord injuries and allowing clinicians to systematically evaluate sensory and motor functions, make prognostic predictions, and plan effective treatment strategies, right? So, I want you to be able to review more of this one, um, the looking at the motor key muscles on the left and the right, and then the key sensory points while assessing light touch and pinprick. And you can see over here, you know how it is add up all together, 50 for each side for motor, and then 56 for each side for sensory, and then of course one for light touch and one for pinprick. Okay, so let's also discuss the main long tracks of the nervous system. Okay, so we'll talk about the three major pathways, its their functions and their decussation. So what is decussation first? It refers to the crossing of the nerve tracks from one side of the central nervous system to the opposite side. So decussation is essential because it results in contralateral or opposite side control and sensation, meaning that the left side of the brain processes sensory input and controls motor functions for the right side of the body, and of course vice versa. This crossing occurs at specific points within the pathways of major tracts in the nervous system. So let's have an overview of the decussation and function of the primary long tracts. The lateral corticospinal tract. So its function is primarily responsible for voluntary motor control. Okay, it's especially for fine skilled movements in the distal limbs, such as our hands and our fingers. Okay, so where's the pathway or decussation? So the pathway begins in the motor cortex, okay, where the upper motor neurons originate. Okay, and these neurons then descend through the internal capsule, okay, and the brainstem, and then reach the medullary pyramids in the medulla, which is in the lower brainstem. Okay, so about 85 to 90% of the fibers decussate. Okay, we know that there is one that is uncrossed, okay, another fiber. So 85 to 90% of the fibers decussate or cross at the pyramidal decussation, where in the lower medulla, and it contains the descending lateral column, okay? And it descends in the lateral column of the spinal cord on the contralateral side and forming the lateral corticospinal tract. So what happens to the anterior? So the remaining fibers which do not decussate, like again, that does not cross, it forms the anterior corticospinal tract, and it controls the proximal and axial muscles. So injury to the lateral corticospinal tracts above the medullary decussation in the brain or spinal cord then will result in motor deficits on the opposite side of the body, so before it decussates. While injuries below the decussation, so below the lower part of the medulla, will cause deficits of same side already, okay, because it already crossed over. So the second pathway is the posterior column medial lemniscal tract, okay? So this is responsible for transmitting sensory, okay? The word posterior, remember that. It's for transmitting sensory information related to fine touch, vibration, proprioception, which is for body position sense, and also pressure. So what's the pathway and decussation of this tract? Sensory receptors in the periphery, so this is ascending tract, okay? It detects stimuli and sends signals through the dorsal root ganglion and will enter the spinal cord, okay, right? And they will enter through the dorsal columns, okay? These specific kinds of sensory information. So the fibers from the lower body will then travel, okay? Remember, there are two portions of our posterior column. One is the fasciculus gracilis, which is more medial portion of the dorsal column. And these fibers is from the lower body, okay? And then we have the we have the fibers from the upper body will travel to the fasciculus cuneatus, which is more lateral portion of this dorsal column. So I hope you could look at the anatomy again, okay? So these fibers then ascend. Listen to this one. These fibers ascend ipsilaterally on the same side. These fibers will ascend ipsilaterally on the same side up to the spinal cord to the medulla. Okay? And then in the medulla, these fibers synapse with neurons in the nucleus gracilis and nucleus cuneatus and then decussate to the opposite side in the medial lemniscus. Okay? So in your handout, it says in the internal arcuate fibers of the lower medulla. So it still ascends to the medulla and then it crosses over. But remember, this is ascending. From there, they will ascend again to the thalamus, right? And then the thalamus is the relay station, and then it will finally send or ascend to the primary somatosensory cortex in the parietal lobe, right? So what's the clinical implication for this? If there is lesion in the posterior column medial lemniscal tract that is above the medullary decussation, okay, like in the brainstem or brain, will cause loss of fine touch, vibration, and proprioception in the opposite side of the body. Okay? But if the lesion is below the decussation, below the crossing over, okay, it already crosses over, then in the spine, it will lead to sensory loss on the same side as the injury. Okay? So just look at where the decussation is. Okay? The last pathway that we're going to discuss is the anterolateral system pathways. So the function of this system, remember, it's also called the spinothalamic tract, okay? It carries sensory information related to pain, temperature, and crude touch. So the pathway and decussation is different from the two. This is a sensory receptor in the periphery which will detect painful or temperature stimuli and send signals to the spinal cord that will also enter through the dorsal root ganglia. So after entering the spinal cord, these fibers those synapse in the dorsal horn with secondary neurons, right? So there's first neuron, and then it will synapse in the dorsal horn with the secondary neurons. So then the secondary neurons immediately decussate within the spinal cord, either within one or two segments of their entry point. And it is through the anterior commissure. Okay, so after crossing, so remember it's crossing in the spine within the spinal cord, one to two segments above. After crossing to the opposite side, they will now ascend in the anterolateral column of the spinal cord as the spinothalamic tract. Okay, then again, this will ascend all the way to the thalamus also. Okay, it will synapse over there, and then it will project the information to the primary somatosensory cortex. Okay, so due to the decussation occurring in the spinal cord, okay, the lesion in the anterolateral system will then cause the loss of pain and temperature sensation in the opposite side of the body, but where it's below the level of the lesion of the spinal cord. Okay, so let's have some sort of let's summarize it. The lateral corticospinal tract decussates at the pyramids in the lower medulla, and it controls again the voluntary motor function, especially in the distal limbs. Okay, the posterior column medial lemniscal tract, it decussates, or this is the dorsal column pathway. It decussates in the medulla, and it carries fine touch, vibration, proprioception, and pressure sensation. Another tract for sensory is the anterolateral system, or the spinothalamic tract. It decussates in the spinal cord near the entry level and transmits pain, temperature, and crude touch. So the decussation of these pathways is crucial to understanding the effects of spinal cord and brain injuries, as the site and nature of sensory and motor deficits depend on whether the lesion is above or below the point of decussation. That's why the decussation area is very important to know whether is it ipsilateral affectation or contralateral affectation. So over here is an overview of all the tracts that we have in our spinal cord. So remember, whatever ascending and descending tracts you have on the right side of your spinal cord, you also have ascending and descending tracts, on the left side. So they're both symmetrical. So let's just read from here. So we have the lateral corticospinal tract. Okay. It crosses over or decussates over in the pyramid, is responsible for the distal limb movements, voluntary distal limb movements. Okay, so your lateral reticulospinal tract, vestibulospinal tract, ventral reticulospinal tract, they're responsible for axial and proximal limb movements. We know that there are two fibers of the corticospinal tract, which is one lateral and one ventral. So this one is the crossed, and the ventral is the uncrossed corticospinal tract, and this is responsible for the distal limb movements, and they're just very minor role and fewer fibers. Okay, so the ventral spinothalamic tract on this side is one of the two major ascending tracts. This responsible for carrying the pressure and touch, okay, or crude touch, while the posterior column, okay, is responsible for the other sensation, which is joint position, vibration, and pressure. So, and then it has also two fibers, the fasciculus gracilis, okay, in the medial area, okay, responsible for the lumbosacral, which is for the lower extremities, and fasciculus cuneatus, which is more laterally located, but responsible for the upper extremities. Okay, so the dorsal root is very important to remember because it is where the sensory information enters after the ganglion, right? We have the spinal thalamic tract, right? The lateral spinal thalamic tract, which is responsible for pain and temperature. Okay. So how about the dorsal spinocerebellar and ventral cerebellar? So the dorsal spinocerebellar tract and ventral spinocerebellar tract, they are two main pathways that carry proprioceptive information as well, but and it's related to the body position and movement from the spinal cord going to the cerebellum. That's why it says from the spine, spinocerebellar, where it is used for coordinating balance, posture, and fine-tuning voluntary movements. So both tracks are essential for unconscious proprioception but have distinct routes and characteristics. Okay. So let's move on to the spinal cord injury, different kinds of damage to the spinal cord through different kinds of injury. Okay, so when you say spinal cord injury, it can be due to injury, disease, or congenital. Okay, so the first spinal cord injury type, depending on the mechanism of injury, is the cervical flexion rotation injury. So it is the most common type of injury, okay, and it is in the cervical region, therefore the name cervical. And the mechanism of injury is this is a rear end motor vehicular accident that produces flexion and rotation injuries, thus the name cervical flexion rotation injury. So what happens is, so this is the posterior side and there is a flexion, okay, flexion plus rotation. Okay, the posterior spinal segment, spinal ligaments, looking here, will has rupture, and also the upper vertebrae is displaced over the one below, looking over here, right? So there is also a rupture of the IV disc in severe cases, and the anterior longitudinal ligament rupture can also occur. This is where here, anterior longitudinal ligament. The transection of the spinal cord is often associated with this type of injury. So we also have the hyperflexion injury, okay? So this is a pure hyperflexion force causes an anterior compression, fracture of the vertebral body with stretching of the posterior longitudinal ligaments. Okay, posterior longitudinal ligaments right here, and the ligaments remain intact, however. So the force sustained by the bony structures leads to wedge type. You can see the wedge type fracture of the vertebral bodies. Frequently severs the anterior spinal artery, okay, and results in an incomplete anterior cord syndrome, as the anterior spinal artery provides innervation or blood supply to the anterior cord area of the spinal cord. So there's a head-on collision or a blow to the back of the head which will cause the hyperflexion injury. Another injury is the hyperextension injury, and this is common in the older adult as a result of fall, okay, and going backwards. So individuals' chin often strikes a stationary object and leads to neck hyperextension. So the force ruptures the ALL, the anterior longitudinal ligament, and compresses the ivy disc. And the spinal cord can become compressed between the ligamentum flavum and the vertebral body with a resulting central cord type of injury. So central cord, as it actually pinches the central area of the spinal cord. Okay. So another one is a compression injury. So with the compression injury, it's a vertical, okay, it's a vertical compressive forces that can injure the cervical or lumbar spine. So just like the diving accidents, it can cause injury with combination of compression and some flexion forces. So there is a fracture of the vertebral end plates and movements of the nucleus pulposus into the vertebral body. Okay. Right. The nucleus pulposus will go inside the vertebral body. Okay. So there are two types of spinal cord injury. Okay. So you can call someone with quadriplegia or paraplegia. So quadriplegia is also known as tetraplegia, which damages the cervical segments, resulting in the paralysis of the upper extremity and all the way down. So the paraplegia is a damage from the thoracic and lumbar spinal cord segments, which paralyzes the trunk and below or the lower extremity. So we have also spinal cord injury classification, okay? And remember that the spinal cord injuries are classified by the lowest spinal level that is intact in function. So when we say complete spinal cord injury, therefore there is an absent bowel and bladder. It may have a zone of partial preservation, meaning to say the dermatomes and myotomes that are caudal to the neurological level will remain to have partial innervation. It is incomplete, if bowel and bladder function is present. So the amount of muscle strength present below the lesion, we can say Asia scale C, D, or E. C if less than 50% of the muscles below the lesion has 3 out of 5 muscle strength, and greater than 50% of the muscles has a 3 out of 5 muscle strength. And then of course Asia E is normal strength. And again, we'll talk about the different syndromes of the spinal cord depending on the part of the spinal cord that is injured or affected. So I'm not gonna go anymore with this Asia examination, as I have discussed this one already. But just to let you know that again, we have 28 dermatomes on each side, and then there are 2 sensory assessments, one for pinprick and one for light touch. And then the total number of score is 56 for pinprick and 56 for light touch. And then of course that's for right side, and then the other one for left side, 56 and 56. So with the 10 myotomes on each side for motor exam, remember you grade it from 0 to 5 out of 5 MMT, right? So it includes a test for each innervated level of the upper extremity and lower extremity. So there are 10 myotomes on each side, okay? The motor level determination. If a muscle has at least a grade of 3, then you can consider that to have an intact innervation. Okay, we're not going to discuss that anymore. We have already talked about that. So first, spinal cord syndrome is the complete transverse cord lesion. So the spinal cord transection, looking at this spinal cord, it results in complete disruption of all sensory and motor pathways at and below the lesion. So you can see that everything, all the parts of the spinal cord has been affected. Okay, nothing is spared. So if you look at this spinal cord, it shows the dorsal column, lemniscal pathway. It shows also the lateral spinothalamic tract, okay, and then the motor ones, okay, the cortical spinal tract, okay, and one is ventral and one is lateral uncrossed, right? So the green one is again the pain and temperature, which is your lateral spinal thalamic tract. So you can see then, therefore, motor and sensory are both affected. So how about anterior cord syndrome? So looking again in the anatomy of this spinal cord, the anterior portion of your spinal cord is affected. And in the anterior portion, watch which tract, which tracts are affected. It affects the motor and then pain and temperature. Therefore, the vibration and position sense is intact. So this is typically caused by a flexion injury, and it damages the anterior and lateral spinal cord with or without vertebral fracture. So again, there will be bilateral motor, which is the affectation is in the corticospinal tract, and pain and temperature, okay, the green portion, and which is the spinothalamic tract, okay. So the only one that is spared, again, as I said, is the dorsal column. So that's for vibration sense, proprioception, right? There is bowel and bladder and sexual function that is intact due to sacral sparing, okay? How about the central cord syndrome? So in this, you can see what's affected is the central area of the spinal cord. And what is spared is your lateral spinothalamic tract and a portion, dorsal portion of your dorsal column pathway. So the damage to the central aspect of the spinal cord with sparing of the peripheral portions of the cord, okay, it commonly occurs in older people following the extension injuries to the neck. And the tract fibers innervating the cervical segments are located closer to the central gray matter. So meaning to say, the central gray matter is in the middle, right? So here is cervical, here is thoracic, here is lumbar, and then outside is the sacral area. So that's why, okay, the sacral portion, which is for the genital area, right, bowel and bladder, is spared, okay? So it results in more upper extremity weakness than lower extremity weakness because it's more centrally located, okay? So person is typically ambulatory, okay, because it could have spared the lumbar and sacral area, but loses function of the arms and hands as the central and thoracic area is more affected within the spinal cord, okay? So here's a special syndrome that I want you to remember, as it, you know, most often than not, the question arises regarding the kind of affectation of a spinothalamic tract, okay? So this is a unilateral spinal cord injury, meaning to say only half of the spinal cord is affected. So it could be a gunshot wound, a stabbing or burst fracture of a vertebral body on just one side of the spinal cord. So what happens is, right, so it affects the corticospinal tract, this red one, the motor. It affects the corticospinal tract, and the affectation is ipsilateral loss, Why is it ipsilateral loss? Because remember, the point of decussation of the corticospinal tract is in the lower portion of the medulla. If this is if this is your brain stem, okay? So this is the crossing over, okay? It will cross that way. So this is below the point of decussation. Therefore, if there is a severance over here, it will be ipsilateral loss of motor of the corticospinal tract, and as well as the proprioceptive sensation. Why is it also ipsilateral? Because remember, the point of decussation of the dorsal column is also in the lower portion of the pyramid or your medulla. How about, why is it a contralateral loss of pain and temperature? Because the anterolateral tract damage is crossing, remember, it crosses over in the spinal cord. If it enters here, okay, it goes up 1 to 2 segments and cross over. Okay, so if the affectation is right here, if this is the nerve, if this is where the part that is damaged, it will be contralateral loss of pain and temperature opposite. Remember that. It's opposite or contralateral. Okay? And it's below. Okay? They're all below, but the anterolateral tract damage is contralateral loss. So I'll just have you watch these are good YouTube videos for the different kinds of pathways explaining the decussation. Over here, we'll show you a little bit also of the spinothalamic tract again. You can play the video. So remember, there are first order neuron and second order neuron. So the first order neuron is the one that's located in the dorsal root as it ascends coming from the periphery. And then the second order neuron is where over here, this is the second order neuron, where the first order neuron synapse to communicate to the second order, and it will ascend all the way to the spinal cord, going to the thalamus. All right, so remember that conus medullaris injury is a mixed upper motor neuron and lower motor neuron symptoms. Why so? Because the conus medullaris somehow is just a tapered spinal cord, so it will still have some part of the regular spinal cord, right? And remember, within the spinal cord, above the anterior horn cell, that's still an upper motor neuron. Okay. The cauda equina is then a pure lower motor neuron injury. And just to remind that the lower motor neuron injury, these are the symptoms. It has paralysis, but it's flaccid compared to a spastic paralysis on the upper motor neuron. Okay? The reflexes is areflexia or hyperreflexia compared to an upper motor neuron hyperreflexia, right? All right, so lastly, we're going to talk about functional potential relates to the level of spinal cord injury, starting from the cervical region. So from C1 to C3, okay, if this is affected or injured, the diaphragm will be paralyzed because the diaphragm is innervated by C3 to C5. So therefore, with patients that are C1, C3 level SCI, it requires mechanical ventilation. And what kind of wheelchair will they use? They can still use the sip and puff power wheelchair. There will be no neck movement to help, okay? C4, there's now a full innervation of the diaphragm because partially will be innervated by C3 and C4, okay? And then, of course, the only one that's not functioning is below C4, which is C5. C5 and below. So C4 is fully innervated. I mean, diaphragm is fully innervated, and then therefore, it will require full mobility and activity of daily living care because remember our brachial plexus starts from C5, C6 to all the way to T1, and it's where the arms and lower, upper extremities and hand functions are from. So C5, when you think about your myotomes, okay, what's functionals are your deltoids, right? Abduction, elbow flexion, right? And then your rhomboids, which is your scapular retraction. So there's limited functional ability in bed. They can do biceps and elbow flexion and a little bit of their and their abduction of the shoulder. What are the functional potential for patients that are C6SCI? They're already independent with rolling. Okay, they could do the biceps curls. Okay, they could start feeding and dressing themselves and propel a manual wheelchair. So remember this level, okay, where bed mobility, I mean, bed rolling starts to become independent. Okay, C7 is now independent in self-care, okay, as long as they have elbow extension, right, and then they will use this tenodesis effect. C8 can live now independently, right, and they can have function up to their fingers, and then says can perform wheelies in a wheelchair. In the thoracic region from T1 to T9, okay, the T1 T9 level has the potential for trunk control and now can do productive cough. Okay, for T10 to L3, okay, this level, the patient has the lower trunk ability and hip flexion strength. And then, of course, they can use the manual wheelchairs. They have the upper body strength, okay, fully innervated. Able to ambulate for exercises and will use the orthosis. So L2 is hip flexion, L3 is knee extension. So they have at least up to knee extension, okay. L3, L5, they have quadriceps function, able to ambulate with orthosis as well. So we'll stop on this part of our lecture, and we'll have part 2 for our physical therapy intervention, which we will discuss more in our laboratory time.